Thank you so much. It's truly a pleasure to be here today and to be moderating this very exciting and impactful session on implementation science and suicide prevention. As many of you know, we really stand at a pivotal moment in clinical practice as we're seeing this unprecedented rise in computational tools, including AI and other predictive algorithms developed specifically for the healthcare setting. But the next step in this journey is really the rigorous and ethical application of these tools to maximize their relevance and clinical utility. And specifically, the potential for improved outcomes in suicide prevention, the theme, of course, of today's conference, is truly boundless. However, the translation from these computational tools to their deployment in impactful clinical practice, that is, for realizing their potential for saving lives, really requires the application of sound principles of implementation science. So for the next hour, you will be hearing from two leaders in the field discussing research and its potential at the intersection of implementation science and suicide prevention. So first up today is going to be Dr. Steve Bartels. Dr. Bartels is the James J. and Jean H. Mungen Chair in Health Policy and Community Health in the Department of Medicine and the director of the Mungen Institute at Mass General Hospital. The Mungen Institute is made up of 13 centers and programs dedicated to translational population and healthcare delivery science, focused on populations with complex needs and health disparities. Dr. Bartels is a national expert in implementation science, past president of the American Association for Geriatric Psychiatry, and former chair of the National Institute of Health Dissemination and Implementation Research in Health Study Section. The title of Dr. Bartels' talk is What is Implementation Science and Why is it Essential to Suicide Prevention? Our second speaker is going to be Dr. Colin Walsh. Dr. Walsh is an associate professor in the Department of Biomedical Informatics, Medicine, and Psychiatry at Vanderbilt University. He also works as a practicing internist and clinical informatician. Dr. Walsh is the founder and principal investigator of the Walsh Lab, which focuses on translating healthcare data to action through machine learning and decision support for vulnerable populations, including specifically those with suicidality and mental illness. Dr. Walsh will be presenting Crossing the Last Mile, Surveying the Next, Challenges and Opportunities in Implementing Decision Support. So I welcome our two speakers today, and also as a reminder, please enter your questions directly into the Q&A if you have them, and we'll be addressing them after the two speakers. Thank you. Steve, over to you.
Okay, I hope I have the right slides here. Looks right. Great. So I'm really pleased to be giving you a brief overview of this issue of what is implementation science and why is it essential to suicide prevention. What I'll be emphasizing are several issues. First of all, what do we know? Is suicide preventable? How are we doing? What does the data show? And what I see as the research problem and why implementation science is one of the answers. And then a bit about successful examples of implementation prevention interventions and what are facilitators, and then a little bit about learning health systems and finishing with kind of what a national perspective is on this. So first of all, what do we know? Well, is suicide preventable? Well, there's many systematic reviews of many randomized trials. And the overarching conclusion is that there's a substantial evidence base of effective practices for preventing suicide. So we pretty much know what to do. There's lots of complexity here, but certainly there's been lots and lots of research over the past few decades that have contributed to our evidence base and knowledge base. One example, for example, is a multi-site study, including one of our investigators here at the Mungen Institute, Carlos Camangar, which looked at an intervention in emergency rooms. And you can see here in this large randomized trial that was done in many emergency rooms across the country over different phases, that compared to treatment as usual, that the screening and then intervention had an impact on reducing suicide risk and reducing suicide. So we do have examples. This is one of many, many, many that we know. However, despite millions of dollars spent on research to prevent suicide and millions of dollars around programs, what do we have to show for this in terms of actual impact on the population? Well, what you can see here is that suicide rates have actually increased since the year 2000 by almost 36% in both men and women. Suicide is responsible for almost 50,000 deaths in 2022, about 1 death in every 11 minutes. And if you think about also individuals who have suicidal ideation or thinking about suicide, many, many more, and many more have attempted. And if one looks at the cost, the impact of this, not only around lives lost, but actually suicide and non-fatal self-harm cost the nation over $500 billion in aggregate costs. So this is a major problem that we still have much work to do to actually impact this, have the science have an impact on population rates of suicide attempts and actual suicide completed. So in essence, this is an illustration of what we call the research problem in implementation science. About 10 to 50% of research actually ever gets implemented in usual care, and it's been documented that it takes about 7 years to implement only about 14% of research in practice. This is a huge gap. It's what we call the KNOW, K-N-O-W, gap between what we know and what we do in practice. Complicating this further, and you'll hear more about this in a subsequent panel, is that there's great inequities that also are pervasive in healthcare and also particularly in mental health care and in suicide prevention. And we know that findings from research, when they do get implemented, are inequitably distributing, perpetuating long-standing health disparities. To further illustrate a best case scenario, what if we had a suicide prevention intervention that was 100% effective? We don't, but what if we did? So it's only as effective as if it's adopted, practitioners are trained to deliver it, practitioners choose to deliver it, and at-risk populations are accurately identified and receive it, and it's sustained. Well, in a best case scenario, you might hope that we're maybe doing this 50% of the time in each one of these levels. Maybe that's not a best case scenario, but let's say 50% of each one of these levels is achieved. So if you multiply that out, if we only are 50% good at any of these issues of implementation, we only have 3% benefit. Just think about that. 100% effective, 3% benefit, that's the gap. So what is implementation science? Well, a definition that's been used for decades now is that this is the scientific study of methods to promote the systematic uptake of research findings and other evidence-based practice into routine practice to improve quality and the effectiveness of health services. So it's a study, it's a science, and it's about uptake of research findings or things that we know to be effective. Now, implementation affects many of the outcomes that we worry about all the time, including things such as uptake, sustainability, the cost of care, safety, quality of care, quality of life, and yes, mortality and morbidity. So it actually affects everything that we do in our science, I believe, and those of us who are implementation scientists are really fully committed to this idea that our science and its impact on populations is only as good as our implementation, and that everything in terms of many of the things we aspire to do are impacted by implementation. So just as an example, how do we measure implementation? How would we know if we got it right? Well, this is one of the most commonly used frameworks or outcome measures called REAIM, which is a short acronym for Reach, Effectiveness, Adoption, Implementation, and Maintenance. So this is about measuring how do we know we reach the targeted population? Boy, is that important in suicide risk assessment. Do we get the right people? Do we know that it was effective? Have we figured out ways to measure the downstream impact around suicide rates or risk or actual attempts or actual completed suicides? Is it adopted? Do organizations take it up and use it? Is it implemented with accuracy? Does that evidence-based practice get used with faithfulness to the way it works best through science? And then over the long term, does it continue? Does it sustain? Does it maintain? This is a big problem in many of the things we put in place, that they work for a while and then they get dropped. And that's what we call sustainment. Now, there are many things we think about as we test implementation strategies, which is the thing we as implementation scientists test. We often assume or know that the thing that we're testing works. It's like, what is the strategy that's going to work to put it in place? Well, classic is education and training. We know that only goes so far. That's the conventional approach, right? But then there are things like audit and feedback, monitoring the extent to which people are doing the thing and then giving them feedback. Clearly, electronic health records are really important in informatics. Technology-assisted mobile health interventions, you'll hear some about that. Using coaches, using people in the community to assess, identify, and support individuals at risk. There's the usual array of toolkits, guidelines, and algorithms, technical assistance, things called learning collaboratives, where we bring together healthcare providers to learn about best practices and study them and change them over time. Many implementations either succeed or fail because there's a lack of champions or internal facilitation, people on the ground that are doing the thing and making sure it continues to be done appropriately. Then sometimes it requires practice redesign, really having almost engineering principles to make sure that the intervention fits in the flow of a complicated setting like an emergency room that's very busy and taxed by many different demands. Sometimes financial incentives or behavioral economics are used. And then there's things that we call learning health systems, which I'll make a few comments about in a few minutes. So what contributes to successful implementation of suicide prevention interventions? Well, there's actually been a study of this also. And what you can see here is there's about 64 studies in aggregate at this point in time that have focused on what we call facilitators and barriers to successful implementation of suicide strategies. These facilitators and barriers follow most of what we know in implementation science literature on what are the things that characterize likely success and likely failure of implementation. So first of all, if the thing is more effective, the intervention is clearly more effective than usual care, healthcare systems, clinicians are likely to want to do it. If it's only marginally more effective, maybe not. Also, it has to address patient needs related to increased risk, that it actually not only just assesses and identifies people at risk, but does something about the things that are contributing to that person's increased risk. Third, it's helpful and also important that it's adaptable to the local setting and population, that actually one intervention in one place may not work in another or with a given population, whether it's a minority population or a special needs population. We need to be able to adapt what we do for the setting and the population to make it work. Low complexity really helps, and low cost. On the other side of the fence, things that are high cost, low advantage, not clearly better, don't reflect or address unmet needs, not particularly adaptive, and very complex, don't do well. So those are the things we know at this point in time about things that are more likely to have uptake and success in implementation. Well, how do we, one of the things I mentioned here is this issue, and you'll hear more about this later, how do we think about implementation strategies that address patient needs and healthcare delivery inequities, which are really important? Well, work on addressing inequities in implementation strategies has been done over the years, and many of the basic principles are based on this very early work or in 2020 by Bauman and Cabasa, which is the following set of principles. Focus on reach from the beginning. Start with the idea you want to reach as many people at risk as possible. It's not good to do a really good thing with a small number of people. You need to be able to reach those most in need. Design interventions from the inception to reach vulnerable populations and low source communities with implementation in mind, if you really want to have successful reach. Implement what works and develop strategies that can reduce inequities in care. And furthermore, develop this science of adaptations, which we in implementation science talk about, where we take things and adapt them for setting, population, or context. And then finally and importantly, use an equity lens in evaluating implementation outcomes. So those are things that will really, I'm sure, be talked about later in a subsequent panel on health disparities and inequities. However, here's one of the problems, and I know that Dr. Walsh, who's an expert in this area, will be talking about this some. If you look at this algorithm on the right-hand side, which is one of many algorithms for screening and delivery of interventions for suicide prevention in emergency room settings, looks pretty complicated. Well, suicide assessment and suicide delivery prevention is in fact complicated in complex settings that have high demands. So how do we do this? And as I discussed, things that are complicated in terms of interventions don't do that well in implementation unless there's a way to either simplify them or to deliver them in ways that leverage some of our new capacities. And as Dr. Foulkes pointed out, our newfound capacity to use artificial intelligence is hopefully going to be really a game changer in terms of addressing both complexity in identifying people with the highest suicide risk and complexity in delivering the intervention at the site where it needs to be delivered with fidelity and with effectiveness. So the levels of complexity are many, and our hope, obviously, is that AI and other related technologies are going to be helpful in terms of addressing the complexity that is inherent in suicide risk and prevention, and maybe one of the reasons why we haven't been that successful in moving the dot around suicide rates nationally, in addition to the fact that implementation has been suboptimal. Well, what do we really need to do if we want to change the rates of suicide and have a real impact downstream? I'd suggest that one of the things that we really need to aspire to, and this isn't just with suicide risk and prevention, this has to do with basically improving healthcare at large, is to develop and engage what we call learning health systems. And this was a concept that has been developed by the Institute of Medicine many years ago, now the National Academy of Medicine. But this is about using data combined with informed patients and families and informed provider teams and evidence-based practices in partnerships to improve care where it's delivered. So in this learning health system paradigm, we would hope that we would be able to use data on the right side here that is delivered to feed forward clinical data, and ideally using AI and being able to automate not only the algorithms, but the way that we identify high-risk interventions, to have this fed to the provider team on the other side to actually engage in partnerships with patients and families that are empowered to develop the best interventions and the best strategies for creating real change in healthcare delivery systems. And that this is all informed by scientific evidence and new methods that are bubbling up from those of us who are researchers to improve what we do in team science. The components really of learning health systems that are effective include these elements such as data science and informatics, patient and family and provider partnerships, a continuous learning culture. This is not a one and done. This is a constantly evolving application of new science, new data, new ways of evolving what we do to improve care, and research which is dynamically changing, not fixed, but actually research results which are being continually adapted to the setting and the context. And ideally, again, that this is all aligned with payment mechanisms, that it makes sense from the standpoint of cost, saved lives, but also saved unintended or unnecessary hospitalizations, or downstream morbidity and the results of the impact of suicide attempts. Well, I'm going to finish on kind of a note of good news, I think, which is that if we think about what constitutes the current national strategy for suicide prevention, which is well worth looking at as we have this Suicide Prevention Month, that the Department of Health and Human Services has described a set of number of goals that we have to pursue. This is available to you on the web if you so choose to access it. But I think what I wanted to highlight here is there are 15 goals. 5 of them really have something to do with implementation. So there is, in fact, an investment and a recognition that implementation is critical here. And that what we have is, in fact, a focus on integrating suicide prevention into the culture of the workplace and other settings, implementing research-informed suicide prevention, implementing effective prevention services as a core component of healthcare, improving data and quality of the data, and then implementing suicide prevention strategies for populations disproportionately affected by suicide, with a focus on marginalized communities, persons with suicide-centered life experience, and youth. So again, I think there's hope. I think we're moving in the right direction, but clearly the investment that we have to make in suicide prevention needs to clearly emphasize this issue of implementation and implementation science as we go forward if we're really going to make a difference. So with that, I'm going to turn my slides and my production over to Dr. Walsh, who will be the next speaker. Thank you.
Terrific. Thank you so much, Steve. And thank you everyone for joining us this morning. And I'll bring up my slides so we can get started. So Steve's talk was just a fantastic overview of so many key concepts in implementation science. What I'm going to try and do with you over the next 15, 20 minutes or so is talk to you a bit about our work and other work in doing something called crossing the last mile. And in the space of implementation, that last mile is often the space between, we have that idea, now we want to actually deliver it, whether it's to providers who are making decisions at point of care or directly to individuals who are themselves experiencing suicidality. So no disclosures for you today, and given our time, I'm going to jump right in. So I have a few goals and objectives I'd like to make explicit. First is to highlight barriers to implementation. We heard a lot about those from Steve a few moments ago. I'll talk to you practically about what some of those look like as we get down to the local population and local setting. I'll talk a little bit about evidence that suggests decision support may affect clinical decision-making. I'm not saying a priori whether that's positive or negative. We obviously hope for the positive, but it's important to study that. And finally, in an event like this, I think it's fair to say, the hope is to inspire. Hundreds of individuals are joining us today. And, the idea that we may spawn some collaboration or some further investigation in how we move forward as a field, I think would be really exciting. And finally, I'm going to leave you, I'll have this quote from Louis Pasteur from a nice paper on implementation research cited at the bottom right there, that essentially says, we find great satisfaction in science in discovery, but our cup of joy is full when the results of these studies find practical application. So if we reach one of you out there, who are not only excited about your discoveries, but get you a little bit closer to filling that cup, then I'd say that's mission accomplished for today. So how we'll get there? We'll talk a little bit about finding a roadmap, how we actually cross that last mile, so we're not figuring it out as we go. What lessons did we learn along the way? I'll go through each of these, so I won't read them to you now. And then I also want to challenge the field, the group of you joining us today, to think about where we go next. There are so many challenges to implementing decision support or any real suicide preventive system to try to improve care. But that said, where are we going to be in 5 years? And what are the problems that are coming after we try to solve this next batch is something I hope to share with you before we close. So there's a modeling focus to my talk. I won't talk a lot about predictive modeling today, but just to give you a sense of level setting, our work, like a lot of studies, was partly inspired by a meta-analysis. So Joe Franklin and Jess Ribeiro were at Vanderbilt with me a few years ago. And this meta-analysis that came out looked at a swath of accepted predictive instruments, screening tools in this space, and found that in meta-analysis, their accuracy was often found wanting. In parallel, there was this explosion, and there continues to be an explosion of papers and now more practical efforts to actually implement predictive models closer to the point of care, or really the point of decision making, if it's not in a traditional healthcare setting. And our work falls into this swath as well. So just to give you a sense of how much is out there, I mean, it's at least hundreds of papers, if not more. Now there are multiple systematic reviews just about predictive models in the space of predicting suicidal ideation, attempts, and death from suicide. So we set out to try to solve a gap that we certainly found locally, and I think is reflected in other medical settings, which is that we had screening tools in practice at the medical center, but when we look into our data, we frequently found that individuals who subsequently experienced a suicide attempt we couldn't find evidence that there had been a screening opportunity. And there are many papers, I won't go into them all now and talk about them in interest of time, that show that there are very recent healthcare encounters around events related to suicide and around the world, internationally. And so that's that gap we really tried to tackle in our work here. Might we build models, more scalable models, more automatable models that would add to routine suicide risk screening that's happening at the point of care? So that's where we started. Now, when we started this work, we didn't have the roadmap. So this is the roadmap for purposes of today. One paper that emerged as a result of this work is really this 5-stage model to what this team, Chris Linzell, Bill Stead, and Kevin Johnson at Duke, Vanderbilt, and Penn, respectively, termed action-informed artificial intelligence, essentially taking an algorithmic approach and then matching it to a solution, matching it to a system, implementing that system. And what does that take? So there's 5 stages to this approach. I'm not going to work through every one. Because we're focused on the last mile, my focus for today is really going to be on the latter stages, the last 2 stages. In brief, where this starts, where our work started and where a lot of work of this type goes, in that first phase, it's problem formulation. It's stakeholder engagement. It's starting those conversations that don't stop with the first phase. They continue all through the 5 phases of implementation. It's the R&D, actually developing the tool. And if it's an AI tool, it's the model development, it's the model validation. It's that flag we plant in literature saying, hey, this is a new algorithmic approach, or we took an accepted algorithmic approach and we applied it locally in our setting and it works well. And so we'll proceed with that. In that third stage, there's replication. So replication is the idea we've tested it in one population, typically a training data set derived from a local electronic health record, but then we want to see what happens in other data sources, what happens in similar patients, what happens in disparate patients, those who look different. How do we replicate it in simulation? There's lots of ways to approach that. So really robustly testing, understanding the problem, developing modeling solutions, testing them rigorously. That's a lot of what those first 3 stages are about. The second stage is focus on designing, testing, and deploying the tool, and then testing whether those outcomes are improved. And I'll talk more about those in some detail. One key element of this work practically is, as much as you can see line of sight to that last stage, that roadmap, all the way to stage 5, that will help inform decisions that are made right in stage 1, right when we're defining the outcome we want to measure, right when we're defining what might go into an algorithm. So again, that's all I'll say about those first stages. Now let's move into stage 4 for our particular work. So many groups like ours will take a data set, develop what is now, popularly called healthcare artificial intelligence tools. I'm a big tent guy. AI has been around for 70 plus years. It's not a new concept. We have newer, later, and greater tools, and that's constantly going to be evolving. But the reality is a lot of supervised machine learning problems start similarly. We develop a data set that represents the outcome we care about predicting. We test whether the algorithms can predict that particular outcome. And then as we move through those first few stages I just talked to you about, we move closer to an implementation. A key element of that work I wanted to highlight is there's a critical advance moving from a research data scientific space into a more implementation data scientific space. What that looks like practically is what we're calling here silent mode. We're not coining that, just essentially saying the idea that running an algorithm that's been trained in a lab in a clinical system, in a live clinical production system, is a critical step. Presuming that the model will work as well in that setting is frequently not true. I'll show you an example in a moment where we learned some differences. It also opens the door to asking more questions. So for example, how does a statistical risk model predicting a suicide attempt work in a production system? What happens when we start to integrate automated model inputs with the face-to-face screening that's happening every day in our clinical settings? Both of those questions become a little bit more plausible and a little bit more realistic when we're now testing them in clinical production. What we learned from that, and this is one of the key lessons for the day, is context. So a key aspect of implementation, moving from clinical research to implementation research, is understanding context. And as you see in this quote here, it's the idea of moving past an efficacy study where we're controlling for context, or an effectiveness study where we're tolerating context, to truly engaging with the context. I think that's the key word here. We're engaging with context. I'll give you 2 examples of context in a moment, but there's lots of more ways to think about context for purposes of your work and certainly ours. One type of context to think about is modeling context. So in that perspective validation paper I highlighted a few moments ago, we had an opportunity to test whether an algorithm trained on a really large sample of data performed equally well across clinical setting. The short answer is it doesn't. In our particular model, we found, and this is an area under the receiver operating characteristic curve for many of you, 0.5 is as bad as it gets, not 0, to give you a sense. 1 is as good as it gets. Suicide attempt being a rare outcome means AUROC can actually be misleading. It can look spuriously high, simply related to the rarity of that outcome event in a model that's partially specified. And what we found in our work was that this model, if we sought to just flip the switch and turn it on everywhere, it would frankly be no better than a coin flip in our behavioral health settings. It was a big problem. And we make implementation decisions on the back of understanding this context. Models have performance in aggregate, the largest data set we can find, but as we get down to local settings, the site of implementation, model performance can look different. The good news is we can test that, and we can test that before we turn on any systems that actually change decision-making at the point of care. A second type of context I'll highlight is clinical context. And this context essentially suggests if we understand aspects of the clinical settings in which we'll be implementing a given approach, and this is bigger than predictive models, it helps constrain in a good way our choices around that implementation. So I'll explain what that means now. So on the back of that work, we imagine a system that builds on screening that's happening anyway. So for example, in our hospital, as in many, universal screening is happening in our emergency departments for patients who walk in for whatever reason, as mandated by the Joint Commission. Well, we imagine a system like this one on the left side of the screen. Imagine a computational automatic risk screen that now can add to the mix. In some cases, it'll catch something a person might miss. In other cases, it'll be wrong, and the person's going to catch risk that the model doesn't see. But understanding the context of use, whether we're screening every patient or not, is a big factor in terms of how we design systems on the back of those risk models. So the idea here being this automatic risk screen, whether there's a high risk suggestion from a predictive model, may immediately prompt clinicians to think about doing something a little bit differently for this patient versus the last one. If the model says there's no risk there, perhaps the patient's in a setting where they're going to be screened anyway. So there's another chance to catch that risk. There's an opportunity to then synergize those 2 points of prognostication. And in any case, all of these could be passed to evidence-based prevention that's fit for that patient at that time. And then on the back of all of that, once we've made some of these steps computable, a big lesson we've learned in understanding context is just to turn these kinds of systems on requires us to measure better. And what I mean by that is we have a better sense of how we define something that I can say to Steve, in a sentence, but how do we teach a computer to find it? And once the computer can find it, it allows us to track and monitor and coordinate care a little bit better. There are detours along the way as we're crossing the last mile. And one of them in the space of suicide prevention is stigma. So we conducted some human-centered design work with collaborators in the military. This is specifically a U.S. naval study where we're understanding some desiderata and potential barriers to implementing systems like these in primary care and U.S. naval settings. And one really critical quote, I won't read it to you here, all of you can be doing that in your offices or at home, essentially saying, this stigma came through right away. And this is a barrier as well as an opportunity for us to destigmatize a clinical problem like suicide. Around the idea that now we're talking about scaling algorithms to prognosticate risk of suicide, and we can do that on millions of people in seconds. There's a tremendous responsibility there. There's a tremendous potential unintended consequence or set of unintended consequences there we have to think about. This is both a barrier to implementation and also in evidencing our understanding of issues like this is an opportunity to build trust and collaboration with those stakeholders we're working with in building solutions. Another detour that we personally have run into, and I've heard from numerous people who do work like this in the field, is this algorithm. I'm calling it the algorithmic misconception, sort of like that therapeutic misconception. I'm not an ethicist, but it's something we do think about in our work. In the case of algorithms, essentially what it says is at some point, and I've had this conversation more than once actually, well, your model, quote unquote, works, right? So why wouldn't we just give it to everybody? It's this idea that a model validated to have some accuracy metrics in the literature means there will confer the same level of accuracy for individuals, which is often not the case. It presumes that we have, and Steve, you really nicely spoke about this before, even if a 100% effective intervention exists, there are still reasons it doesn't happen 100% of the time. All of that's wrapped up here as well. So even if a model is accurate, there are all these reasons down the line why things don't necessarily translate to effectiveness in practice, and more. Another key lesson for the day, and this is probably one of the most important ones, is this sense of what I'm calling ask and learn, just keeping it simple. Pre-design, during design, post-design. Asking and learning from those that we're working with is so critical. It sounds so simple for me to say that, but I often say to those on my team, one of the most important skills that data scientists could possibly have is the ability to listen, to sit and understand the world that individuals live in when we're designing these systems, such that we help as much as we can and harm as little as possible. So just a couple of quotes, again, from this work with the Navy, one provider being explicit about where in the decision-making they felt like a modeling type solution might help them. Another provider talking about the fact that there are individuals who come in who are negative on one particular screening, but then they get screened a little bit further and it turns positive. So it's this idea that this risk prognostication is hard on a good day. And now we're designing tools to hopefully make that better, but there are challenges every step of the way. And then in the design, so I'm showing you a highlight of what's called the user-centered design framework. The key thing to take here is that this is a fundamentally iterative process. As you can see, it's loops within loops. And the idea is that every step of the way, you have opportunities to course correct, you have opportunities to learn something new, and real willingness to be agile and adjust design to reflect that, I think, is a critical skill to develop on a team like this one. I'll talk a little bit about inertia in a moment. You'll hear more about this idea. Now, within the design itself, we can actually design tools to learn more from those individuals using the tool. So this is a screenshot of some decision support we implemented in a randomized control trial last year. You'll hear a little bit more about that in a second. Doctors Ashley Spann and Allison McCoy are two key designers here. I wanted just to highlight their great work. This is called the Best Practice Advisory, something that lives within the EPIC electronic health record. And what I really want to highlight here, I'm not going to take you through every aspect of this, so of course you're welcome to read about it or ask me about it, is feedback. That's actually the point of this slide, is to show you that we built feedback right into the tool. And what we've learned, and we have data to back it up, is providers and clinicians using this particular tool as they're thinking about what a risk model is suggesting, potentially, will you screen this person further because the risk model suggests so? They will give you feedback, and they'll give you feedback at the moment they're interacting with the tool. It's another opportunity to ask and learn. And we received feedback along the lines of, okay, I'm screening on the back of this particular alert. We also heard from a number of providers who said, I don't even know why your model thinks this could be relevant for this patient. And that kind of candid feedback is very, very helpful. As we're moving toward a learning health system, it means we need to take every type of signal we can get. The positive, the negative, this comes out of left field. Why are you even suggesting this to us right now? And in the world of where alert fatigue, the idea that providers are bombarded with things like this in their daily practice, we have to remember, we have our particular model we're implementing. There may be 5 other ones that a provider is going to run into just in this case, in the space of one interaction. So we have to know we're designing in those kinds of settings. We conducted a trial on the back of this decision support I'm describing to you. We had an interrupted version of this signal, which is shown in orange. We had a less interrupted version shown in purple. And the point of this particular slide is to show that when we implement systems like this one, it does lead to changes in behavior and changes in decision-making. So over a 6-month period, around 600 encounters and 70 providers, we saw 40% of the encounters where that best practice alert I showed you was triggered, prompted screening. The baseline in this particular setting was 8% the year before. In the non-interruptive, the rate was much lower. So there were key differences between how we implemented this system in terms of how providers acted on it. There were also key differences adjusting for those provider effects. We didn't see any episodes of ideation or attempts in either arm of this particular study, but important to know that these systems, and this dovetails with other spaces in the literature, the urologic literature, literature on blood transfusion, sepsis prevention, these systems do change decision-making, so we see that impact. What we're really interested in the next phase as I move into opportunities is the idea that how do we build these systems as part of really an end-to-end learning health system type approach that helps patients at every step in their journey, not just in this particular clinical encounter, where this particular system happens to be live. So now, where do we head to next? One challenge I want to pose to everyone is, a very hot topic in the literature right now is multimodal data modeling. I'm showing you an image from one of the most highly cited papers in this concept, came out of a great team from Stanford, showing what happens when we take different modalities of data. In this case, it's audio data versus video data, and then building representations of those data and to fusing models together to try to build what's called a multimodal model. So in some subdisciplines, in some computer science disciplines, multimodal confers a deep learning component of that. More broadly, multimodal is the idea that if we get more signal from more different types of data, it might make the model better. So that's sort of the table stakes for today. What I want to challenge all of you to think about is how do we get toward multi-model systems? So the idea that there's not simply one algorithm prognosticating a probability of one event and we spend 2 years developing a system to drive decision support. It's the idea that we're going to have algorithms at every step of the way. And how do we handle that complexity? How do we handle the error estimation? How do we handle the explainability and interpretability of that? How do we prove systems like that are more effective? I think that's going to come in the next 5 years. And I would just challenge those of you listening in today to think about how do we get there? Secondly, I want to highlight another challenge, which is inertia. So I'm highlighting here the work of Dr. Sharon Davis at Vanderbilt, who studies something called drift. Drift is the idea that, it takes so long to turn some of these systems on. You've built that predictive model. We get it implemented. By the time it goes live, it's out of date. The outcome has changed. The rate of change, the incidence has changed. The features you're using to make those predictions, something has changed within that system. The patient mix has changed. So those models look different now. So how do we move from systems that drift at the moment we actually go live to systems that allow us to more holistically look at being more responsive, more preventive, more preemptive, and overcoming this inertia? That's just drift. I mean, there's other types of inertia to think about, but that's, I think, another key challenge. Having systems that are more dynamic that's a key step to getting toward a learning health system. And then finally, we work so hard to turn systems on to test whether they're effective. We're rapidly going to find maintenance is a key issue. And many research groups are fantastic at the development and the deployment, but maintaining tools, what does that look like? How do you mature these types of systems? That's a challenge. And then when do you need to sunset them? When do they need to go off? How do we assess that rigorously? What's the governance, the monitoring, all the questions that are necessary to figure that out? So that's where we were today. The idea that there are roadmaps out there to guide you in your work for those of you who are seeking those practical implications, the lessons we've learned, where we're going next. And I'd love to talk more about that in Q&A. Lots of individuals' work highlighted here, so I'm just kind of breezing over that. But I'd love to move to question and answer now.
Thank you so much, Colin and Steve, for those truly insightful talks. We have a number of questions that have come through, and also want to encourage everybody again to use the Q&A feature in Zoom to enter your questions if you have them. So I'm going to start with you, Colin, a question, and of course, Steve, you can weigh in as well. And it's sort of a follow-up on what you were just mentioning about multiple model approaches. And the question from one of our audience members is, can you speak to the degree to which efforts to predict suicide are effective across cultures? And I might add to that sort of the bigger question about algorithms that we know reflect existing healthcare biases and disparities, and how we can avoid implementing these algorithms in a way that doesn't worsen those disparities.
Absolutely. Terrific question, and thank you for that. So the mode has been to develop the largest possible data set with the most generalizable data we can and build the model so the sample size is as big as possible and the outcome, the dependent variable, whatever that is as large as possible. I think what we've learned rapidly is that produces a model that might look good in aggregate, but then as you get down to the local setting, the local culture, the local group of individuals, it may fail. So there's a couple of aspects of this. One key thing is that there is a rapidly burgeoning science there. Our chair is Dr. Peter Emby, has a term algorithmal vigilance, which we use a lot these days. The idea that understanding as much as we know and frequently as when we take the time to ask and listen, we learn that there are individuals who historically we may be misattributing risk to. We may be more inaccurate for a given culture or not. Critically, working with individuals of that culture, having them on the team as much as possible, having them be part of the modeling team as much as possible, such that we look for those groups, we help to understand the factors that contribute to those disparities, and then we can correct for them. So if we're vigilant, one, we may say, hey, this model is just simply not appropriate for that individual. There's a parallel, parallel work that we're doing informing genetic analysis in large-scale biobanks, and a similar issue is true. So many studies were built around European ancestry populations, which certainly doesn't solve the problem globally. And so improving, sometimes it's a data issue. We don't have the right data to speak to it, so we're better off not making a recommendation. And other times there's ways to correct it. So the key is to acknowledge that that's a challenge, to be algorithmo-vigilant in our implementations, and then really, again, that partnership, having the multidisciplinary, multicultural partnership, I think is really the number one thing to take from that. So I'll pause there.
Thank you. Steve, do you have anything to add to that?
No, I think it was.
Okay, we'll move on to the next question then. So Steve, this is one I'll ask of you first. And it has to do with the translatability, and you had that wonderful slide where you talked about uptake and the sort of 50% times 50% times 50% end up being only 30% effective. And this question is about the effectiveness of online interventions, particularly when working with areas in rural areas or areas where mental health care is difficult to access. Can you talk about the effectiveness? Particularly, they're asking about online interventions, but more generally, when you think about that sort of perpetuation of lack of uptake, how that might affect differentially across different populations.
Yeah, it's a complicated question, but let me give it a shot. I think online or mobile health interventions for behavioral health, mental health, have been developed in great amounts. In fact, there's so many apps that are out there that it's actually daunting. Clearly, in terms of rural settings and having reach to set individuals who are at risk, having face-to-face encounters is just not possible or scalable for everybody. And so mobile health interventions online makes sense. At the same time, there are issues with respect to broadband access and things like that continue to be a problem. But even in developing nations or low and middle income countries, access to smartphones or some sort of capability is pretty broadly disseminated now and better. So that's not as much of a barrier as things that are effective that people continue to do. And the literature on many of these apps is that they're used a couple of times, and then the sustainability of them, both in terms of use and in terms of impact, is really modest at best. So I think one of the biggest challenges in developing these and using user-centered design and design thinking is about not only engaging people and starting to use them, but figuring out ways, whether it's through gamification or all sorts of different things that have been worked on, to have people continue to engage. And then the question is, to some extent, not if in implementing these things, whether or not you need a human. It's like, when human, what type of human, when, where, what, and how. So anyways, there needs to be a stepped capability to engage the human individual when necessary, to be both engaging in intervention or an assessment when the time comes. And so that's an algorithmic approach that absolutely, through what's called stepped care, can be done, has been done. I think is probably the answer, which is, I'm not sure that will ever completely replace that human element, although there's some really interesting work, and I'm sure Colin can talk about this too, around developing avatar AI-generated responses that mimic and in many sense do pretty good jobs in therapeutic interventions. And those are absolutely being developed, tested, and brought out in large number at this point in time. But again, I think this issue of sustainment and continued engagement, and then figuring out how to bring people into a crisis setting when things really go in an area that the app is no longer going to make an impact, are many of the challenges that persist.
Yeah, so I think you're bringing up several themes that we heard, and Colin certainly touched on, of sustainability and making sure that any intervention really is sustainable, and developing methodologies for evaluating that sustainability. So really, how do we evaluate that, and then also not just multiple modalities input into the models, but also multiple approaches or modalities to treatment and prevention strategy. So really important points. I don't know, Colin, if you have anything additional to add to that, or Steve kind of covered it. Okay, so this is a question I'm going to throw out to both of you, and either one can pick it up. Is there any work on building sequentially adaptive implementation strategies that are cost effective? For example, starting with a low cost implementation strategy, and then for non-responders, consider costly options. And related to that is sort of the question of really, how do we implement these kind of complex algorithms in more simple ways? Colin, do you want to take a first stab at that?
Sure. Yeah. So by parallel, there's a lot of work currently around this problem of treatment selection or recommending the right treatment. And this speaks to that multiple model concept I spoke of before. We focused for so long on risk prognostication in there, but there are some really exciting work where groups have been trying to quantify effectiveness in samples to say, well, this is not, don't just make me worry, as our providers told us, right? Great. I like the idea that your algorithm might help me identify risk, but now help me do something that isn't just worry about what I'm supposed to do next. So that's one example where we start to, take the example of depression management, for example. If a patient sees me in primary care and there's a low cost intervention in SSRI that's going to be a great fit for that patient, reinforcing my decision empirically could be really helpful. If a patient, and this is work underway, if a patient may actually be the kind of patient who's going to try that SSRI, they may or may not tolerate it well, it may or may not be effective, they're going to proceed to more advanced treatments, more expensive treatments, different types of utilization, maybe end up in an emergency department. The earlier we know that, potentially allows us to say, okay, so in this group of patients, these individuals look like they're going to respond to that low cost, more scalable intervention. And this is a group we're going to keep our eye on a little bit more because we may want to escalate care for them or think about them a little bit differently. That's a really topical, timely approach individuals are working on. I think it's one example as we get to the vision you laid out there. I'd love to hear, Steve, your thoughts on this as well.
Yeah, this is really, I like to think about the fact that so much of the implementation science we've been doing have been kind of not particularly intelligent trials. They're A versus B trials. And so there's a thing called a SMART design, not because it's smart, it is smarter actually, but sequential, multiple assignment, randomized trial designs, factorial designs, things that are adaptive. And if you think about it, the paradigm we've been using that we've been studying as scientists doesn't mirror real care at all. Nobody sticks with one thing for 3 years to test whether or not it works with a patient. You modify. And so there are, in fact, in implementation science, also adaptive trials, adaptive interventions that actually are, in fact, much smarter or more adaptive and do, in fact, change in the way that the thing that's being delivered is delivered or tested at each level of uptake or effectiveness. That is the future, I think, and really much more in the dynamic model of science and of research.
Thank you. Okay, this next one, I think also both of you will have something to say about. It's related to privacy. We have a number of questions around privacy and also sort of policy with respect to that. So I'll ask two questions here, two different audience members. The first is, I know that often people will use the last question from the PHQ-9 to screen for suicidality. Is that the best question to ask, particularly given that many individuals fear being involuntarily committed and may not be honest? Is there a better question to ask? Does making clear the circumstances under which involuntary commitment reduce the degree to which people may give a false negative to the question? And then the second question related to this is, what are your thoughts around regulation and cybersecurity protections for such AI digital tools and interventions? So really big topic. We could probably have a whole session and more on just those questions of sort of privacy protections, honesty related to that. Any thoughts, Steve? Do you want to start?
Actually, I'll flip it over to Colin and then I'll follow up with some thoughts because I know that Colin's thought a lot about this around the use of AI and large models with confidential information. And then I'll make a comment. Go ahead, Colin. Yeah.
Right. Yeah. So this is an area we've run into many challenges. We've worked with groups related to the military. We've worked with groups from different cultures around the country. Certainly groups within our medical center. Stigma, again, the idea, covert distress is a really big problem here. And so, as we've worked with military decision makers at times, people are smart and they know if they're being screened for something and this might have an effect on their career, or it might have an effect on they're worried about their insurance, or they're just worried about the stigma. They, as we learned in talking to the U.S. Navy, no, never next, right? There were many sailors who understood what to say to pass the screening when they themselves might have actually really been suffering at that moment. And so some of the things we've learned in doing that work is that there were other signs for those around them to often see. It was something as simple sometimes as the way someone's hair looks 1 week to the next can be a sign to say, hey, something seems off with this person and let me engage. And so I don't know. I mean, I don't want to get over my skis I don't consider myself an expert in developing a new screening instrument where we're asking what's the perfect question. I think critical is to ask that question, knowing that there is help on the back of that question, that this is not a question that relates to judgment or ends up with some pejorative happening for that person after the fact is really critical. If systems like the ones we're talking about today can prompt consideration of that question, or even as much as possible doing scripting. I mean, there's fantastic work out of the VA, our friends at VHA who've done work prompting. Well, what do you say if you're contacting someone where an algorithm suggests that they're at risk in the work of ReachVet? I mean, there's a lot of brilliant thought that went into like, what do you say next? So I think knowing to ask, knowing that what to do based on the answer, I think is really critical. And then as it gets to privacy, essentially just having that front and center. There are just so many ways to handle privacy. And the key as much as possible, so in a lot of our work to be agile, is we build in situ. We build in systems people are already using. And that frequently, so in our electronic health record at Vanderbilt, we're using data that's already in a chart that if a provider had unlimited time and resources they could read, we're letting an algorithm do that in seconds to try to add a prognostication the provider may, in a busy day may miss. That's a big hope, but it's all being done where the privacy bounds are similar. And on the regulatory compliance question, a huge work in progress. Having a conversation for one implementation yesterday around 20 CFR Part 11 in the FDA, it's complex. And to worry about it early, have experts who've worked through it before on the team, because it's going to become a barrier at some point, sometimes sooner rather than later. And it can take a really long runway just in the United States to get through regulatory compliance. And then you go to Europe where GDPR and other types of compliance make it even harder. So there's we could have a whole day just on these issues. So I'm going to stop there. But so thank you for those thought-provoking questions. Steve, please.
Yeah, I'll just comment on the clinical issue here around, I think somebody mentioned involuntary commitment as an end stage for people who are at high risk. As a medical director for a state's mental health system for many years, this came up all the time, the extent to which involuntary hospitalizations either helps or don't, and it's pretty mixed. And so I think this issue, ultimately, despite all the algorithms we will have, there's no substitution for good clinical judgment and for developing a relationship with the patient and the family that's empathic, but also clearly assessing properly that person's potential options, alternatives, things that respect their autonomy, respect their independence, but also acknowledge, when there's really a safety issue. So this is a complicated thing. I'm not sure we'll ever have an algorithm that will fix this.
So we have exactly 1 minute left. So 15-second soundbite for each of you. The final question is there hope? And particularly with AI, the question that came from our audience is with the new opportunities with AI. I know many of us are sort of what we call doom scrollers, and we see the numbers and it's, can bring us down. So the question for you all is, do you think that there's hope going forward?
Colin, go ahead.
Excuse me. I mean, absolutely. I'm inspired every day that there's hope. The idea that we have newer, more easily accessible tools that may help in our reach, may help in our ability to do the right thing at the right time is really inspiring. And it's going to take great collaboration, asking and listening. It's going to take rigorous evaluation to show that systems using tools like that are effective. And if they're not, we don't use them and we use to something else. I think I'm endlessly inspired daily. So Steve, please.
Yeah, I'm very hopeful. As somebody who lost patients to suicide early on in my career and struggled with the decision around whether the information we had was really helping to inform the risks. I think we're so far ahead in terms of the clinical capacity with AI and other sorts of capacities to develop real predictive models that will help enormously. Combining that with implementation science, combining that with the capacity to put things in place that really work, make them scalable in so-called learning health systems, I think there's great reason to be hopeful. And then finally, the reason I presented that last slide on kind of the United States, the HHS policy and the investment in suicide prevention is substantial. And I think this is recognized as a real health crisis. And those are all reasons to be optimistic that we're on the precipice of really doing some things that are going to be much more effective in moving that dot in terms of suicide rate.
Great. Well, thank you again, both. Really wonderful panel discussion. Thank you.